All right, good morning, everybody. Let's go ahead and get started. My name is Ian Saldana, and I'm an associate professor here in the Department of Epidemiology at Johns Hopkins Bloomberg School of Public Health.
您知道还是挺好。
Welcome to this monthly seminar of the Johns Hopkins Center for Clinical Trials and Evidence Synthesis. Today, we are very glad to have Dr. Cong Chen as our speaker. Dr. Chen is a scientific associate vice president in early development and mid-stage oncology statistics at Merck and Company. He's located in Pennsylvania. Here's some details about Dr. Chen. He has a master's in mathematics from Indiana University and a PhD in statistics from Iowa State University. Prior to his current role at Merck, he led the statistical support for the development of Keytruda, or pembrolizumab, and played a key role in advancing its regulatory approval. As part of his work at Merck, he develops and advances statistical techniques for early to late transitional oncology programs and supports the company's external collaborations. He's an elected fellow of the American Statistical Association. He's an associate editor of statistics in biopharmaceutical research, and he's a member of the Cancer Clinical Research Editorial Board. In addition, he leads the DIA Innovative Design Working Group. He's published over 100 papers and 10 plus book chapters on innovative design and analysis methods for clinical trials. And he's given multiple short courses at various statistical conferences. Dr. Chen will present to us today about two-in-one adaptive phase two, phase 3 designs in clinical trials. Over to you, Dr. Chen. Thank you for doing this and welcome.
Thanks, Yang, for the invitation. Nice introduction. I think I should turn off the video just to save some bandwidth. And Amy, thanks for organizing it. Really a great honor to be here today. So today I will just give you a brief introduction of two-in-one design for oncology drug development. So what's the two-in-one design? Drug development is a very systematic, stepwise process. Findings from small studies are incorporated into the planning and design of larger and more definite ones. However, the participants from these earlier studies are excluded from the formal analysis of subsequent studies. In this context, as is common in scientific research, the process of generating hypotheses and confirming hypotheses are independent of each other. So that's kind of a status quo in conventional drug development. And for this matter, that's kind of status quo for scientific research. The two-in-one design tries to do something different. In the two-in-one design, participants from earlier study are included in the formal analysis of a subsequent study. Our research has demonstrated the first time that this design is statistically valid under a mild mathematical condition. In other words, data used for hypothesis generation can be properly incorporated into hypothesis confirmation without compromising the scientific integrity. The mathematical condition is typically met in phase 2-3 oncology drug development, which will be my focus of presentation today. As this is an introductory session, I will try not to get into the mathematical details. So let's apply this to the phase 2-3 oncology drug development. In oncology, drug developers rely on very limited efficacy and safety data from small single-arm phase 1 trials to determine whether to proceed with a randomized controlled phase 2 or phase 3 study. Those single-arm phase 1 trials have a primary purpose of dose finding, and after dose is identified, patients may be enrolled for some preliminary signal detection, basically to see whether the drug can induce some tumor reduction in certain patients. And once the developer sees some signal, then they start to debate what to do next. Of course, if they don't see anything exciting, it's an easier decision. But if they see
应该
something
如果
seems to
你
be
提供了这个功能了，但是
exciting, what to do becomes a very challenging decision. On one hand, they want to directly go to phase 3 to shorten the timeline of development. But on the other hand, there is tremendous risk of doing that. But if they do take the traditional approach of conducting a randomized phase 2 controlled study for more solid proof of concept, it's going to take much time. Typically, it's going to take 2 years to finish. And oncology drug development is always on a fierce competition. So if they take a more conservative approach, they're afraid that competitors may beat them on the market. And under the 2-in-1 design, they actually can relax a little bit at least. Now they can start the trial as phase 2 randomized, and then take a look at the data to decide whether to continue this as a phase 2, as they probably would be, and or decide whether to directly go to phase 3. If they decide to go to phase 3, a nice thing here is that the patients used for the decision making will be included in the final phase 3 analysis. So in other words, at the end of the day, either a positive outcome at end of phase 2 or a positive outcome at end of phase 3 is going to be a success. And they can rely on partial information from the trial itself to make such a decision. That's why it's called 2-in-1. Overall, the 2-in-1 design not only improves the quality of decision, because now you have more data to make a solid decision, but also it's more efficient than the conventional approach. So what does it look like if you incorporate this 2-in-1 design into phase 2-3 drug development, oncology drug development? Well, instead of to have to debate whether to go to phase 2 or phase 3, which has different risk proposition and different implication on the timeline, now you start to think about other options. For example, if you really want to go to phase 2, you ask yourself a question whether it's feasible to expand to phase 3 in the middle of trial for potential drug approval. If the answer to that is yes, then you can consider this 2-in-1 design strategy by specifying in the protocol. Otherwise, you just go with the conventional phase 2. On the other hand, if your bias is leaning towards straight phase 3, you ask yourself a question whether it's desirable to mitigate the downside risk. And if the answer to that is yes, you switch to the 2-in-1 design. And otherwise, you just go with traditional phase 3. So there is a question, don't we? Well, it's disappeared. I will answer that at the end. Now, as a result, instead of just 2 options, you have 3. And the nice thing about the middle option is that you can rely on more data, emerging trial data to make a decision, as opposed to just relying on phase 1 data, which is very limited. Notice that if you take this 2-in-1 design approach, the design study itself will end up being either a phase 2 or a phase 3 after the interim analysis. So while the advantages of the 2-in-1 design are evident, But it's challenging to change people's perspective in the real world from a deterministic mindset to a probabilistic one, especially within a highly regulated and conservative industry. So it's not surprising that several years after our first publication, the adoption is not as widespread as I hoped it would be. Although the first official two-in-one design was published as early as 2018, shortly, almost immediately after the publication of our first paper. Now, before I talk about the motivation behind the two-in-one design idea, let me briefly discuss its mathematical foundation. So basically, the statistical validity is mainly due to the so-called Slepin's lemma. Slepin, his full name is David Slepin. He worked with Shannon on information theory at the Bayer Lab. The lemma basically states the fact that probability mass of a bivariate normal variable increase with the correlation between the two variables. And I heavily rely on this lemma to prove that the overall false positive rate of two-in-one design can be fully controlled. Again, meaning that the design is statistically valid. But interestingly, the method we used for the proof actually extends Slepin's lemma under unconstrained boundary to a constrained one. And given that this lemma has a lot of applications in the information theory, our extended proof actually potentially has some relevance to information theory, in particular in the area of dimensionality reduction. But that's not the area that I specialize in, so I just want to, briefly mention about that. So we know that all the theories are great. So why we consider this two-in-one design in practice? The design, sorry, the design was actually motivated by my many years of experience in oncology drug development. As many of you may have learned elsewhere, that one of the biggest scientific breakthroughs in the last decade is the emergence of the so-called PD-1, PD-L1 immune checkpoint inhibitors. I was fortunate to be part of that revolution. Merck's Keytruda was among the first PD-1, PD-L1s to get FDA approved. Since its approval in 2014, the field really took off, as can be seen here in the tremendous increase in the number of clinical trials. And 4 years later, two pioneers in the field were awarded the Nobel Prize. Before the revolution, oncology drug developers were more cautious. They tended to follow the traditional paradigm, which is to first of all use phase one to find a dose and to do some preliminary signal detection in 30 to 40 patients for each tumor indication. And once they see some signal, they want to do a more solid proof concept by comparing the experimental drug to a standard of care or best supportive care to make sure that the drug is indeed working. And if so, they will carry to phase 3. But since the revolution, the mentality of drug developers has substantially changed. The success of this PD-1, PD-L1 immune checkpoint inhibitors attracted a lot of the new players into the field. The worry about missing out the next wave, companies, small or large, started treating all their new drugs like the next Keytruda. They basically start to kind of plunge into phase 3 right after phase 1 when they see some preliminary signal. almost in a herd mentality. Now, enter me. Merck started its oncology program 2 decades ago. I was the first project statistician, and the first drug was called Zonlinza. It was a so-called HDAC inhibitor. We acquired it from small biotech company based on its promising data for the treatment of cutaneous T-cell lymphoma. Cutaneous T-cell lymphoma is a rare skin disease. We bought it primarily because the biopsy would be much easier to access so that we may be able to find a predictive biomarker to guide its development in other cancers. We tried in over 10 other tumors since then, but none worked. And we couldn't find a predictive biomarker despite the availability of the skin biopsies. Biomarker-guided precision medicines are the future, but there is often great uncertainty about the predictive effect of biomarker early on in the clinical development. I will get back to this point later. Merck Oncology didn't take off until the introduction of Keytruda in 2010. And in between, over 20 drugs were brought into the clinical development, and again, none of them worked. So by the time that Keytruda was the Keytruda program was started, we only have one drug in one small indication at Merck. Against this backdrop, when I saw so many unguarded new players rushing aggressively into the oncology field, I was really concerned. The idea of the two-in-one design was born in February 2017, during the heydays of the cancer immunotherapy revolution. Since then, I have supported another 20 or so new projects, but none of them has yet to make it to the market. Meanwhile, despite billions and billions of dollars of investment in R&D, only one new immunotherapy in the entire industry had some moderate success in treating melanoma, and it was subsequently approved by FDA. This is so-called LAG-3 monoclonal antibody. So looking back, the success of PD-1, PD-L1 inhibitors was unprecedented, if not accidental. Minus this immune checkpoint inhibitors, trial and mostly arrow remains to be the norm in oncology drug development. Some of you, well, since most of you are in the academic setting, you probably are not aware of that in oncology drug development, each patient will cost a sponsor approximately $150,000. So with trial costs exponentially increase from one phase to the next, the paradigm of routinely skipping phase 2 is just unsustainable. In my mind, it's overdue to change our behavior, which is spoiled by the success of those immune checkpoint inhibitors. And a two-in-one design should be considered by all drug developers, as long as they are serious. So let's start with some practical examples in terms of how to implement such a design. Let's say you now have some ambiguous efficacy signal from phase 1, and you face a lot of peer pressure to move forward the program. So what can you do? Well, first of all, I just want to mention that the two-in-one design doesn't have to be stopped at 2-in-1. It can be n-in-1 with n greater than 2. And in this case, you may want to start your program as a phase 2, like 200 patients, one-to-one randomization, and then you conduct analysis, interim analysis after about 140 patients, had 3 months of follow-up. By the time you have already enrolled pretty much everybody, but the last 60 or so patients didn't have adequate follow-up, so you don't need to include in the interim analysis. And take a look at data. If the data is meets the adaptation criteria, you expand to a larger study. Otherwise, you keep on going. It doesn't necessarily mean that your study is going to fail. It's just that based on various considerations, you don't want to take the risk. And you can do that one more time. And again, take another look. And if now the data looks really promising, you can aggressively expand to a larger study. And again, if you don't see a very promising signal, you can keep as is. Nice thing in oncology is that while a larger study may lead to a regular approval, so-called full approval sometimes, a smaller study could give you accelerated approval. So you really don't have much to lose, and especially given the fact that you should probably have started from smaller study anyway. And by taking this approach, you at least have the benefit of including those patients you used for the decision making in your subsequent expansion, subsequent study. Now let's talk about another hypothetical 3-in-1 adaptive design. In this case, it's with respect to biomarker adaptation. As I mentioned earlier, as a typical scenario after phase 1-2, even though you have some glimpse of hope for the drug in terms of its overall activity, but sometimes it's just so ambiguous as to whether the drug is likely working better in the biomarker positive population. So what do you do? Well, again, you can start with your program in a biomarker subpopulation, because that's probably the best hope you have for this drug. And you take another look, you take an interim analysis. Well, if in this more hopeful subgroup, you still don't see much, you just keep on following these patients until the end. And in the end, maybe that due to longer follow-up, the drug starts to show better effect, which would be nice. But if in the base case, maybe you want to expand the study into phase 3, but solely in this biomarker enriched population. But on the other hand, if the data shows overwhelming effect, that gives you confidence that the drug may be working in a broader population, because after all, this biomarker level tends to be continuous. When you are trying to use a cutoff to select these patients, it's rather arbitrary. The fact that it works very well in biomarker high population implies that it potentially works well enough at least in the biomarker low population. Now, from these examples, you may be wondering how to set this adaptation criteria. Fundamentally, we have to balance the cost and benefit. And it's always the most important consideration in not only determining the threshold for adaptation, but also in any drug development decision making. When you are proceeding directly to phase 3 with all seeing trial data, you are kind of basically setting an infinitely low threshold, basically, and you don't care. And it's appropriate only when benefit outweighs the cost with certainty. When you have to set this criteria in practice, you can use some holistic argument based on various considerations, or through a more quantitative approach, such as benefit risk ratio analysis that I'm going to introduce. The benefit of a program in this case is just the probability of a positive outcome, whether it's phase 2 or phase 3, given that the drug is active. And the probability is adjusted by the relative value between the two. So in other words, it's a value-weighted power of the study. And in terms of cost, there is a sunk cost of phase 2, but then there is a probability-adjusted cost of additional investment. This probability is determined by the adaptation threshold, and it can mathematically, it's simply the type 1 error times the probability of drug being active plus power of the study times the probability of drug being active. And the benefit cost ratio simply measures the trial efficiency, and its maximization leads to the optimal bar for expansion. Intuitively, the inverse, which is the cost benefit ratio, measures the expected number of patients to study to yield positive outcome, positive trial. Apparently, the smaller the better. And the same idea actually is applied to address a strategic level question, which is to how to conduct proof concept trials. And the result, the paper was published in CCR. So when we, a lot of us are statisticians by training, or at least have some learnings in statistics, we often emphasize type 1 error, which is the false positive rate, and the type error rate, which is the 1 minus the study power in designing a trial. But in oncology, you also have to consider the so-called type 3 error, which is that, when you have a lot of opportunities to invest, those opportunities are defined by lines of therapy, tumor types, which kind of drugs you can combine with, etc. There are just too many opportunities for you to invest after you have passed the phase 1 dose finding and a signal detection. But you have limited resource. As I mentioned earlier, when you invest in phase 2, let alone phase 3, the cost is going to skyrocketing. So how to kind of place your bets more cost effectively. And we use this so-called benefit cost ratio analysis to arrive at the conclusion that the phase 2 POC trials should be slightly underpowered to make the overall investment more cost effective. I know some of you who, especially in academic setting, may not fully appreciate that, because we often are educated to have a well-powered study, but given again that you don't have an infinite resource, but you have a lot of opportunities at hand, whereas there's great uncertainty about which ones are really working, it's actually better off to conduct small POC trials that are slightly underpowered. Just a side note. So let's illustrate the benefit risk analysis with a real example. The phase 3 study will cost us 240 patients in a setting. And once we pass the interim analysis, after about 160 patients had a 3 months of follow-up, by the time, again, all 240 patients approximately enrolled, we will decide whether to enroll additional 360 patients. And for this interim analysis, 20% ORR difference is the target. It's what the study is powered for. And we want to know what's the optimal bar to make for us to make a go no-go decision. Apparently, how the probability of a study drug being active is unknowable in some sense. So the odds of drug being active versus inactive could be 1/3, one half, or 2/3. Here, PROB should read odds. And it's also hard to predict the relative value of positive phase 2 versus phase 3. So we just choose to kind of arbitrary numbers within a reasonable range. It's 1/3, 1 versus 3, or 1 over 5. But as you can tell, the nice thing about this analysis is that the optimal bar is rather robust at about 10%. So in other words, really, for these two biggest unknowns, it doesn't really matter that much. You can safely set the bar at about half of the desired effect to make your decision most cost effective. Of course, in reality, the decision bars can be made based on other endpoints, but the take-home message is the same. Essentially, you need to have observed about half of the effect. That's the kind of sweet spot for the program to be cost-effective. And this bar is, of course, pertinent to the cost structure of this program. If, on the other hand, you want the phase 3 program needs another 2,000 patients to complete. As you can tell, the bar would be higher because the subsequent investment is more. But whether it's 360 or 2,000, that's up non-upfront. So for this parameter, we can have a lot of control. And for the two parameters that we really don't have much idea about, the design, the analysis suggests that the bar is robust. So that's very nice outcome from such analysis. So I hope it's clear now that the real question after phase 1 isn't whether we should definitely move to phase 2 or phase 3. There is a better option in between, which is the 2-in-1 design. And based upon previous example, optimized adaptive 2-in-1 design for active drug has approximately 80% of probability of advancing to phase 3. Of course, it will be lower if the subsequent investment is much larger, as I already mentioned. Conversely, the probability of remaining in phase 2 exceeds 90% when the drug is inactive. So these numbers are not perfect because they are not 100%. But in drug development, there is nothing even close. Overall, this a probabilistic approach based on emerging trial data is apparently superior to the conventional deterministic approach based on a coin toss. Since there are many colleagues from the industry in the audience, I'd like to wrap up with a lesson from a real-world experience that I hope will be relevant to your daily work. A new drug program initiated its phase 2 study in early disease setting in early 2019. The primary analysis conducted in 2022 yielded a positive outcome. Subsequently, a phase 3 study commenced in 2023. Since this is an early disease setting, the primary analysis outcome won't be known until at least 3-4 years later. So what if we had implemented a 2-in-1 adaptive phase 2-3 design from the outset? Well, if the interim phase 2 analysis, which would happen in about mid-2021, successfully passes the go-no-go bar, the study could have been seamlessly transitioned into phase 3. The overall sample size for the program would be smaller because these phase 2 patients will be included in the phase 3 analysis. And the time to finish the program would be at least 2 years earlier. if the interim phase 2 analysis fails to pass the go-no-go bar, as we have already learned, the bar doesn't guarantee, because when you set the bar, you have other considerations. And in addition to this consideration, it could be also that the drug effect is not fully realized at the interim analysis, which you wouldn't know. But anyway, in this case, a separate phase 3 study would still be initiated in 2023 after positive final analysis of this phase 2. However, given that the positive phase 2 outcome is positive, right, as pre-specified in the 2-in-1 design, now the program would be very well positioned to seek accelerated approval because statistically, that positive outcome is the first requirement for any drug approval, and you have already pre-specified in the outset. So as you can imagine, should this program have applied the ADAPT 2-in-1 design from the get-go, it would be much more efficient. So this is just a list of key references that are related to my today's presentation. There are a lot of other 2-in-1 design literatures out there. Most of them are probably more technical than the ones are listed here. And this concludes my presentation, and thank you for your attention.
All right. Thank you, Dr. Chen. That was intriguing and quite provocative and very, very interesting. So much appreciated. So we've got quite a bit of time for discussion now. What I would suggest is if anyone wants to speak up and ask a question, they raise a hand. Perfect, Jay, I see your hand raised. And I know that some questions have come up in the chat and some have been answered in the chat as well. So that's great. But I'll try to bubble up some of those questions as well. So I see Jay's hand already raised. So go ahead, Jay.
Yeah, thank you. It was an excellent presentation, Cong. One thing I guess I want to clarify from you is some patients are entering the phase 3 because they have progressed from the phase 2, but I assume some patients are entering the phase 3 without having gone into the phase 2 first. If that is true, then in oncology, the phase 2, the patients in the phase 2 have been previously treated with various different histories, whereas those going immediately into newly diagnosed, into phase 3 don't have that history. So I wonder, at least in an analysis of PFS, would you include how they got to the trial at least as a covariate? And if you've done that, what is your experience?
Jay, it's nice to see you. I'm wondering if you remember, you were actually one of our DMC statisticians many years ago. I appreciate your guidance always. So I neglected to mention that when I say phase 2 and phase 3, I'm referring to the same disease setting. So they are the same inclusion exclusion criteria. So basically, once you have some signal in certain disease from phase 1, after you apply, for example, Simon's 2-stage design in let's foresee argument in second-line lung cancer, you see some signal, 15% response rate. You got a little excited, but now this 15% response rate may not be so reliable. These patients may have better prognostics or something, and in reality, the same patients with should they be treated with a standard of care, they may generate 10% response rate, for example. As a result, the 5% difference is not that exciting, but that you don't know. And on the other hand, it could be that the patients are very sick, indeed very sick, and if you treat them with a standard of care, probably none of them would have responded. So a more prudent kind of traditional approach in oncology drug development is that, well, you test it in a randomized setting in 120 patients, say, this time you compare to standard of care, and now not only you can confirm or or unconfirm the response rate signal, but also you have opportunity to understand the safety profile, the long-term benefit, etc. After that, you decide whether to conduct a phase 3 study in the same population again. In this case, it could be 800 patient study that's going to cost you over $100 million. Over there, the goal is to test whether drug improves survival. So that's kind of the situation. I'm sure you're aware of. I'm just talking about this for the benefit of the students in particular. So sometimes in reality, a lot of companies, especially those who are spoiled by success of immune checkpoint inhibitors in the last decade, they just plunge into phase 3. They skip this phase 2 randomized phase, which as you can imagine, the outcome, the success rate is going to be low. So what I'm arguing here is that, well, instead of having to choose between phase 2 and phase 3 based on this very limited data set, you can start your program as a phase 2. And if phase 2 it seems to be promising, you can expand into phase 3. And if it's less exciting, you can keep as phase 2. And when I say less exciting, I don't necessarily imply that it's going to be futile, because again, it could be that the data, the follow-up of the patients is not long enough, or it could be that response rate in this particular case is not the best indicator of drug activity. It could be that after the completion of phase 2, somehow you start to see some survival benefit that gives you confidence that the drug actually is working. But the point in line is that by taking this kind of adaptive approach, you now have a better position to make a more cost-effective decision.
Yeah.
So long answers short. So when I say phase 2 followed with phase 3, or phase 2 seamlessly transitioning into phase 3, I mean the same patient population that you have already predetermined.
Right. So then in what we now call a phase 3, they will all have similar backgrounds, is what you're saying.
Exactly. The same inclusion, exclusion criteria.
Yeah. Okay. Yeah. Thank you. Thank you.
Yeah, thank you. Nice to see you, Jay.
Nice to see you again, too.
Great. I'll now turn to one question that came up in the chat and then return to the hand that's raised. And this is sort of along the lines of something I was thinking as well. Riddhi asks, could you help me understand the differences in regulatory processes and FDA oversight for these trials when you compare them with traditional trials?
Right. So I mentioned that the adoption is not as widespread as I hoped for. Nevertheless, it has been already proposed by a lot of companies for a lot of trials. From a statistical standpoint of view, FDA has never raised any question because it's mathematically proven. However, they often make a comment to state to the fact that if your trial if you decide not to expand to phase 3, despite the fact that at the end of phase 2, your trial is still positive, it's going to be a review issue whether we can grant you accelerated approval or not. So this kind of comment is not alarming by any means, because it's just common knowledge that nowadays accelerated approval is scrutinized more closely. FDA has already been burned a few times when they give drugs some accelerated approval. It turns out that the drug couldn't improve the survival. So they are taking a more cautious approach in terms of granting accelerated approval. However, the fact that you already get a positive outcome that's pre-specified put you in a much better position to argue for accelerated approval, if not based on this phase 2 alone, but based on some additional data from ongoing phase 3. Otherwise, you would have to rely more heavily, if not entirely, on the phase 3 data to justify for any accelerated approval. So this is one comment that FDA tends to ask. The other comment is that, well, you cannot pause the enrollment of phase 2 for too long, because if you pause too long, the patients enrolled in the phase 3 portion may have some different characteristics than the phase 2. And more importantly, the standard of care may have changed, or at least the patients may have different availability in terms of the options. So as a result, the treatment effect in the subsequent patients may be slightly different from the previous patients. And this is not, again, nothing too alarming. It's just common knowledge that for any adaptive phase 2/3 design, FDA tends to ask you to have a more consistent outcome before the two kind of stages. So the bottom line is that so far I have never heard a single comment from FDA that challenges the statistical validity of the design itself. It's more about the operation and the clinical practice, along those lines.
Great, thank you. I see Chen, you had your hand raised. If you'd like to unmute and ask your question.
Hi, Cong. Nice to see you here, and great talk. I learned a lot from your presentation. So I just have a quick comment and want to get your thoughts. As you may know that at the NCI cooperative group system, we actually been doing the so-called seamless phase 2/3 trial for a while, and we have been actually a number of examples. Like for example, I recently surveyed the group that I work with, energy oncology, where we identified less than almost 20 phase 2/3 trials in the past 10 years or so in variety of multimodality cancer treatment setting. So I guess my question is that in our practice, we have been considered this more or less as a problem of running a phase 3 trial, but with a rather aggressive fertility rule using a non-overall survival endpoint, assuming overall survival as the phase 3 endpoint. So could you maybe on a very high level, maybe you can just introduce the idea of the 2-in-1 design that you are introducing, like from outset, or more fundamentally, the difference with this mindset or this perspective?
Yes, very, very, very good question. I'm happy that someone asked this, and it's from you. So when traditionally people talk about adaptive phase 2/3 design, it's really a phase 3 design with some adaptation, including sample size re-estimation, including the implementation of futility analysis. So the bias from the get-go is to complete this phase 3 design, unless there is something disastrous or something unexpected that warrants, early termination in this case. And when I talk about 2-in-1 design, it's not really about a design for certain phase. It's actually design across 2 phases. It's more program level strategy. So I'm not hinging upon either phase. You let the data decide which phase you really should go into based on emerging data from the same setting in the same randomized trial. Just that as opposed to the conventional kind of approach, which is to predetermine whether you want to go to phase 3 or phase 2, or not. And the setting you brought up, belongs to the later situation, whereas you have already predetermined a decision. And in that case, when you declare futility, it's bona fide futility. You have no way to rescue the study, even if after you have declare the futility, somehow magically the data looks fabulous at the end. You already don't have the chance to get back. But this 2-in-1 design, tells you that since you are really not married to whether it's to phase 2 or phase 3 upfront, and if you really want to mitigate the risk in case you have decided to go to phase 3, you can declare success even after it has been terminated earlier. And from mathematical point of view, there is not much difference, I would say, except that it allows you to declare positive outcome for the smaller study, but it's more at the strategic level of whether you want which kind of philosophical approach you want to take. That's why I kind of spend about 10 minutes on explaining the current situation in oncology drug development, which is very deterministic and very phase 3 biased. So hope that kind of partially at least address your question.
I see. Thank you. That's very helpful.
Great, thank you. I'm not seeing more questions in the chat, and I think I've bubbled up the questions, but let me know if I've missed anyone's point or question. But one thing that I was thinking about is if you could speak, Dr. Chen, to from the patient perspective or the participant perspective about what the consent process looks like and any ethical implications there might be for this design versus the more traditional
Right.
face-to-face.
Yeah, so the consent form is essentially the same as for typical phase 3 study, and the language we used, just is the same. Basically, we tell the patients that participating in this trial doesn't guarantee anything. There is a risk, and for this matter, the trial could be cut short, after interim analysis. However, patients who are otherwise benefiting will continue receiving the treatment regardless, those sort of things. So really, it doesn't have any difference. That's why the concept, again, at least conceptual-wise, is very complying with the current practice. It's just that a lot of people in oncology drug development, they are kind of spoiled by the success of immune checkpoint inhibitors, and more generally speaking, the kind of the unprecedented success of oncology field in the last decade overall. They tend to just aggressively pursue a phase 3 in cases that they should probably should be more careful about.
Great, thank you. Shangrong?
Yeah, thank you, Ian. Dr. Chen, very, very informative talk, very, very great learning there. I'm just curious, for this kind of design, are we allowed to change eligibility criteria and outcome measure selection between the two, between the different phases there?
Right. The general inclusion-exclusion criteria shouldn't be changed.
Yeah.
However, if the eligibility criteria involves some kind of a simple modification of patient population, in the case, for example, when you want to add like in this case, make it broader than in terms of biomarker inclusion exclusion criteria, you can do that. But otherwise, or other key inclusion criteria, exclusion criteria such as line therapy and lab or ECOG, those kind of things cannot be changed.
Yeah, great. And how about outcome measures, especially?
Right. And that's a very good question. And in this case, if the study ends up being a phase 2, you can use overall response rate, which is a conventional phase 2 endpoint. But if you switch to phase 3, you can use OS. So in this case, the endpoint can be changed. And for this similarly, you can actually change this, adjust the sample size instead of predetermining how many patients you can enroll after you pass this interim analysis. You can use the data to guide you how many. This is kind of a more
adaptive.
more kind of advanced statistical research, and there are already a lot of publications in the field. So bottom line is that all those traditional design strategies, as we are aware of for those phase 3 studies, can be added to on top of this 2-in-1 design. For example, futility analysis, as we mentioned, dose selection in the middle, or endpoint change, or alpha allocation, or sample size adjustment. Those complex features, can all be applied seamlessly to this design, because after all, this design only adds a simple analysis that drives you whether to continue the trial as phase 2 or to switch to phase 3. Once again, once it's switched to phase 3, you can do all sorts of things that you want. So that's why it's really very flexible, and again, it's compliant with our conventional practice in terms of designing phase 3 trials.
Thank you. Yes, it's good to know that it's a simple calculation involved there. But I think this kind of design does require very comprehensive thinking beforehand to think it through there. The estimate, the new estimate framework that FDA has been pushing for, that actually will be very helpful to think through all the aspects related to the design.
Right. On one hand, there are a lot of technical things to think about, like what you mentioned about this estimate. But on the other hand, I would encourage you guys, especially those graduate students, to think broader than just the technical aspect. Presumably, a lot of GHU students will become leaders in the real world, in drug development or clinical research. We also want to make sure that we communicate to senior management, to colleagues around you, to take this kind of approach, not only just this approach or any scientific approach that's proven to be more efficient, and to implement in practice and to make a broader impact in the end to development of oncology drug. And we often complain about the high costs of oncology products, or for this matter, in any medical service. But actually, there's a lot of fat can be cut in my mind based on my almost a quarter century of experience in drug development. Those drug development industry, pharmaceutical industry, and FDA. I don't want to say anything bad about FDA because they are largely helpful, in particular in developing in oncology drug approvals. But they tend to be very conservative. They are very heavily regulated. They are very risk averse. On one hand, they are risk averse in terms of adopting new ideas. On the other hand, they are just they can just follow the herd by jumping into phase 3 in this case, without thinking about too much about the consequence, because they are always constantly under the peer pressure. And for future leaders from GHU, I hope some of you can make a bigger impact at this level to educate people that decisions can be made more objectively, as I show in the benefit cost ratio analysis, or more sounded in terms of the high level strategy, as in this case the 2-in-1 design, as opposed to the traditional kind of deterministic approach based on a coin toss.
That's great, and thank you, Dr. Chen. That was quite an inspiring finish to an excellent seminar and discussion. So we really appreciate you taking the time to speak to us this morning, and thanks to everyone for joining and actively participating. That's all we have time for today. Thank you.
Thank you.